Yes. So, good morning. You are very courageous to be here at 8 o'clock in the morning. I have to just to open the topic about Clubfoot and to define the line in complex Clubfoot. You have to know that you have to reread the past to understand the present. And in the 19th century, Scarpa wrote many excellent papers about Clubfoot, and he said you have to correct gradually the Clubfoot, you see. And at the same time, in my town, Delpech did the tenotomy of Achilles tendon, and you can see the drawing from the very severe Clubfoot up to the correction, and here, from here to here, he did Achilles tenotomy, and this is the patient after correction. So the story of Clubfoot is a long story, and Professor Ponseti was also very interested by the work of Farabeuf, and Farabeuf did a lot of study about ligaments, and he wrote a rule that the more correction you get in the horizontal plane, and the more less equinus you have. So Professor Ponseti wrote an excellent book about congenital Clubfoot, and you have to encourage the new generation to read this book, Gradual Reduction in the Horizontal Plane after Achilles tenotomy and after maintenance of the reduction. But compliance is a problem. It's easy to sometimes to get the reduction. It's much more difficult to maintain the reduction. So it's a demanding protocol. You cannot simplify the Ponseti method. You have strict requirements. You have to avoid pronation. You have not to force, not to speed up for correction. Take your time in the horizontal plane, and after make Achilles tenotomy and correct the foot in dorsiflex. But the Dennis bone is very important. Bracing is essential, but you have not to stick in the Dennis bone. The Dennis bone is not a cage, so you have to stimulate my muscle, and I recommend that every 3 hours you take off the Dennis bone and you wake up the muscle by stimulation with the motor. And I don't think that there is opposition on the French method and Ponseti method, and you must combine the advantage of both methods. You must put more stretching in the Ponseti method, and you will have less relapse. Of course, you have different type of Clubfoot, different strategy, and the stiffer is the foot, and the most difficult is to correct the foot, of course. But reducibility is the most important factor when you classify the foot, and classification is essential. You have many classifications in the literature, but you have to get one, whatever the classification, to clarify category after category the impact of your treatment. A checklist is essential. Don't focus on the foot, check the whole child. Be aware of crease, more crease, more severity. You have a wide spectrum of situation, and start always with the Ponseti method. Don't focus on the foot. Sometimes you have in 10% of cases non-idiopathic Clubfoot. Look for face, hand, spine, and syndrome. And you have different type of situation. Arthrogryposis, for instance, is a very severe stiff foot, and you have to combine with the other deformity as a stiff knee or dislocation of the hip. And look at the crease. If you have a plantar crease, check for the syndrome, and in this case, if patient had a Pierre-Robin syndrome. So surgery à la carte after is essential when you cannot correct completely the foot by the Ponseti method. But be polite with the tendon, avoid large incision, don't provoke anatomy by extensive surgery. Preserve tendon, cheat, and ligament, and use a fragmented incision. And put the motor in your program. By daily stretching, you can decrease the rate of relapse after Ponseti method. And use motion like this to avoid equinus. Push, push, and push every day in the splint. Or you can use also this type of toy to improve the motricity of the foot. So you have to weaken muscle. And by combining these different methods, you can get an excellent result with bracing family French tooth Ponseti. In the neglected clubfoot, you will see it's a challenging surgery, very severe deformities, bone deformities, difficult to catch up, 5 or 10 years of abnormal growth. The bone have lost the morphology. You can see on the right the retraction of the talus in the arthrogepotic foot after talectomy. So you have different options, but start always by Ponseti method, and you can combine the Ponseti method by tenotomy. Avoid extensive release, and in some salvage procedure, of course, you can do talectomy, naviculectomy, triple arthrodesis, external fixation. There are salvage procedure, and you can do correction by the Ponseti method, evaluate the complications, skin problem, compartment syndrome, stiffness, pain, avoid large incision because the foot will burst out like a fruit, you see, after swelling, and use different incision, step by step. Sometimes you can go from the back. You can lengthen the tendon to decrease the tension of the equinus by lengthening the tendon at the junction between the red and white portion. Sometimes you can do posterior release because you have a resistant equinus. But after the posterior release, don't go on the medial part. Go on the lateral side. And on the lateral side of the foot, you can open the metatarsal joint by this incision, and you can make an osteotomy, and so you give room to the metatarsal joint, and you can continue after on the medial part by mean incision. Never do a large incision. There is no need to see the vessel by such approach. You do a plantar release if necessary by this limited approach, you see. And so by a very limited approach. Sometimes you need a talectomy, you need navicular excision because you need room to correct completely the foot. But you can use also external fixation, but you need to be in a department sophisticated with a high technology. It takes time, you see. But with external fixation, you can get gradual correction with the same philosophy as Ponseti. You can decrease the tension of the tissue, and you can get an excellent result by this gradual correction. As you can see on this case, you see, by the application of the Ponseti method, step by step, an excellent result was obtained. But when you are dealing with a neglected clubfoot, you can do also arthrodesis. Double arthrodesis is a salvage procedure. You have to sacrifice a lot of bone, and it's not an easy procedure, and you have to avoid compartment syndrome. As you can see here, you have to make substantial osteotomy to get correction. But it is a salvage procedure, and in such a case, of course, you can get a good result. So thank you very much.